All right, a very warm welcome to you. Please grab your seats. Thank you so much for joining us today. If you can hear me, clap once. If you can hear me, clap twice. If you can hear me, clap thrice. Okay, seats everyone, thank you. So thank you again for joining us today. My name is Krishna Jaffa. I'm the CEO of MEDIC, and it is my honor to be co-moderating this session. We're also going to have a watch party live from Nairobi, Kenya. Hopefully the technology gods and goddesses will bless us, given this is GDHF, and everything will work flawlessly. Today we're going to have a conversation about scaling national community health information systems. It's something that many have dreamed about for a long time. How do you scale? How do you scale with really strong local ownership? You'll be hearing from our panelists who have played critical roles in making this vision a reality. We'll also be joined by participants and panelists at our Kenya Watch Party, as I mentioned, and that's been made possible thanks to the generous support of the World Bank, the Pan-African Informatics Association, and the Kenya Health Informatics Association. And before we dive in, I'd also like to express MEDIC's gratitude to the Bayer Foundation for sponsoring this session. So for those of you who haven't heard about MEDIC, we are the artists formerly known as MEDIC Mobile, and way back in ancient history, we went by Frontline SMS. Today, we are called MEDIC, but if you work with us in any of our country programs, we also go by MEDIC Mobile, so we don't get offended if you call us either. We're a founding member of the Community Health Impact Coalition, and we're driven at MEDIC by a vision of universal health coverage. So really rooted in social justice and equity. And probably no surprise for fellow Community Health Impact Coalition members in this room, we seek to advance the professionalization of CHWs, community health workers, to be skilled, supervised, salaried, and supplied. And if anyone by the door can help shut the door, I would be so grateful. Thank you. Now in our 13th year, MEDIC serves as the technical steward of and primary contributor to the open source Community Health Toolkit, which is a digital public good. We steward a thriving community of practice that is open, so please join if you aren't already a member, which seeks to build local ownership of community health information systems. And you'll hear more from our panelists about this. Very importantly, in solidarity with government and non-governmental partners, many of whom are in the room today, we design, deliver, and support CHT-based applications and support their scaled use by community health workers. These applications or apps are co-created with and for the use of community health workers to deliver quality, timely, and equitable care in their communities. Today, the Community Health Toolkit supports over 62,000 health workers in 18 countries. These include CHWs, supervisors, and administrators. And it has enabled the delivery of over 108 million moments of care within communities. The yellow dots that you can see on the screen are the countries in which MEDIC directly accompanies ministries of health to scale up national electronic community health information systems. We don't do this alone. We do it with partners. Again, some of you are in the room today. Thank you for your partnership. Today, we're really going to zone in on two countries. The first is Zanzibar Autonomous Region in Tanzania, where you'll hear from our partner D3. And the second is scaling the ECHIS in Kenya, which is a journey that's just really gotten off to a fantastic start earlier this year. Next slide, please. Thank you. What you see on this slide, it's quite a busy slide, but this is the Kenya EACHIS dashboard. So this is a snapshot of what is possible if you dream and if you collaborate. On the left-hand side of this slide, you can see that we've already reached 14 of Kenya's 47 counties. We're actively scaling up in an additional 3 counties as I speak. Of the 103,000 community health workers, known as community health promoters, that the Kenyan government seeks to enable and empower with digitally connected health tools, we have already trained and, with our partners, deployed 42,000 or so CHWs. So it's really large workforce, and they're being paid, which is a huge win for the pro-CHW agenda. To date, these community health workers have already enrolled about 1.5 million households. So that's about 15% of Kenya's population. We're so excited and so grateful for the Ministry of Health's leadership in bringing together a really dynamic set of partners. We're equally grateful to Living Goods, who I think are in the room today, for opening that initial door in helping us have conversations with the Ministry of Health that has now made this vision possible. We root this work in universal health coverage. So you see to the right-hand side of the slide that there's a UHC, typical tracer services package that is delivered by these CHWs. They also provide referrals. And we're just so excited to see how this is going to, over time, provide not just a macro level of what it means for a county and a national government to be delivering universal health coverage, but also when you zone in at the community level, truly enabling a future of precision, digitally enabled public health. So with that, I'm going to throw the mic to my co-moderator in Kenya, who hopefully everything's working well there. But before I do that, I'm thrilled to welcome on stage in DC my 2 esteemed colleagues, Stephen Wanye, who is the founder and CEO of IntelliSoft Consulting Limited. They are a CHT technical entrepreneur, and you'll be hearing from him about their story, as well as Ricardo Lampariello, who is the Chief Executive Officer of our long-standing partner, D3 International. Thank you so much to both of you for joining us today. I'll join you in a second. Before we continue here in DC with questions for Stephen and Ricardo, I'm going to first introduce Wambui Kenya, who is our co-moderator in Nairobi. Wambui is the General Manager of Google Search Africa, and she's also a board member at MEDIC. So I'm going to pass the mic to her, and hopefully it's going to work really well. Over to you, Wambui.
Good evening from Nairobi. Good evening from Nairobi. Thank you, Krishna. Thank you, Krishna. All right, we're here live in Nairobi, and I'm joined on stage by John Wanyungu, Deputy Head, Division of Community Health Services at the Ministry of Health in Kenya, and Mary Najoli, who's a community health promoter in Nairobi County, Kenya. Thank you both for being here today. John, I'll start with you. First of all, hopefully the room will join me in saying congratulations. The National Electronic Community Health Information System, EACHIS, built with the CHT, publicly launched in September and October this year. Can we give a round of applause? So John, the roadmap of scale includes equipping 100,000 community healthcare workers with the technology, including community health promoters like Mary, in a pro-CHW world where all health workers are salaried, they're supervised, they're skilled, and they're supplied. How does EACHIS help make this a reality?
Yeah, thank you. We saw, maybe I'll begin by acknowledging that ECHS journey has taken all of us, as well in this room, to bring it up to where we are today. And so ECHS contributes immensely in regard to the 4 pillars of strengthening community health workers, and in Kenya we call them community health promoters. In the area of salaried, we have a listing of all community health promoters in the country through what we call community health workers registry, which we are integrating with the ECHS, so that out of this, you're able to pick details of the active community health promoters and be able to provide that listing to both national government and also county governments, so that it can inform the payment of stipends. Because for us in Kenya, the payment of stipends to community health promoters is co-financed by both national and county governments on a 50-50 basis. So that's how ECHS contributes to the salarying of community health promoters. In regard to supplies within ECHS, we have a community management module, which gives us a update status of commodities. So as CHPs are supplied, they enter the quantities in the system, and as they dispense to households, the system minuses that, subtract that from what they already have. Then ultimately we have real-time status of stock or supplies that CHPs are or community promoters are holding. Then in regard to supervision, we have also a module for community health assistants that guide them on how to supervise community health promoters, especially as they provide services at household level. They're able to pick that and walk through with them, following the supervision module within ECHIS. Then in regard to, so I've talked about salary, I've talked about supplies, I've talked about supervision. There is the last bit that is escaping my memory. Skilled, yes, skilled. And so in regard to skilled, within SHIS, we have a component of the training component. So community promoters are trained, again, on use of ECHIS in a very structured way. So we have a training package of capacity building team around ECHIS that then helps to build skills of community promoters in regard to using of ECHIS. Thank you.
Thank you, John. Mary Karibu.
Thank you.
Maybe we can start off with how long have you been a CHP, and tell us a little bit about your role as a CHP.
Okay, thank you for that question. I have been a community health promoter for the last 14 years, and I have several roles in the community. Number one, for one to be a community health promoter, basically our roles are at the community level. So we do mapping so that we be allocated households that we do our roles. Number two, we do household registration. Okay, another role is to do household visits. Basically, our roles are at the household level, level one. Another role is to do referrals to link facilities. Yes, also another role is to do follow-up. Maybe I've done a household visit. I come across somebody whom I'm supposed to refer to the health facility. After the referral, I have to do follow-up to see to it that the client has been diagnosed, given medication, and also to adhere to the medication. Another role, we have several of them. Okay, it is cutting across other community health promoters in the community. We also organize for action days in the community. We do action days at least once a month. We also organize for dialogue days where we involve community members. Yes, we also do reporting. Work not documented, work not reported is work not done. So we also report to our bosses, community health assistants in the community. We also do defaulter tracing in the community, immunization defaulters for the under fives, also defaulter tracing for those with non-communicable diseases like hypertension, diabetes, also those with HIV positive. If we get such cases in the community, we refer to the link facility. Yes.
Fantastic. And thank you for the life-saving work that you're doing. Roughly, how many households do you cover? And how has EACHES helped you provide quality care and support for those households?
Thank you for that question. After mapping, after household registration, I have 100 households. And all these households are supposed to be visited, not within a month. We do visit households in a duration of 3 months, that is quarterly. The first month, we visit 33 households. And in case we get health issues, maybe if we get cases that are supposed to be dealt with, we also do revisit. We also revisit the households. You cannot just visit a house, you get a case, then you count that you have already visited. We also do revisit. The second month, 33 households, another month, 34 households. Yes.
And how has EACHES helped you in your providing that support?
Okay, initially, we have been doing a lot of paperwork. And some of the tools that we use at the community level, we use Ministry of Health 513, that is household registration book. We also have delivery service book, MOH 514, and also we have MOH 100, that is a referral form. The EACHES has really helped us because all these working tools have been captured in the EACHES application. So it has made our work to be very easy, very flexible. We save a lot of time.
Fantastic.
Yes.
Thank you, Mary. We'll come back with more questions. Krishna, back to you.
Thank you, Wambui. Phew, for a moment there. So I'm going to pivot a little bit to our colleagues here on stage in DC. And it was so wonderful to hear from John. Hi, John, as well as Mary, who is, I think, everyone's champion here today. Good to see you both. And thank you, Wambui. So a little bit of context before we first speak with Stephen. Intellisoft are in the first cohort of the CHT Entrepreneur Accelerator that we also call CHT, TEA, as an acronym, or CHCHI if you're from India. It's supported by the Bayer Foundation, and it's a very close partnership between MEDIC and PATH. So we've awarded 4 Africa-based digital health entrepreneurs with funding to expand their digital health tools for community health. And the main reason we're doing this is that so we can build durable, sustainable, local capacity to support ministries of health. We had a pretty early realization at MEDIC that going to 47 counties, going to 7 countries is not something we can do alone. It's really, really important for us to not just think about partners, but to think about wherever possible partners in country. This is the first time that MEDIC has run an accelerator. So we're super grateful to PATH for helping us on this journey. With that context, Stephen, thank you so much for joining us again. Why did Intellisoft apply and join the CHT Entrepreneur Accelerator?
Thank you very much, Krishna, and good morning, everyone. Good morning, good evening, Kenya. So thanks for having me on stage and on this panel. Our journey in terms of exploring CHT actually started a while ago. We looked at CHT when MEDIC was MEDIC Mobile, so we've been looking at this for a long time, and I think it came from a place where Intellisoft as an entrepreneur in Kenya, very specifically focused on developing digital health solutions, we decided to use global goods from the word go. So when there was a need to start working in the community health level, it was natural for us to look at CHT. And so we did that. I remember we actually did an in-depth evaluation, which we shared with Medic Mobile at that time. And he was very collaborative in terms of, just very receptive in terms of the results we shared with them. And we had a lot of back and forth. And so when this program came around, I think for us it was just quite natural that we'd want to partner with Medic at that time, to work through this together. And I think this came from a place of, we keep talking about building local capacity, but we don't have structured programs, that are well designed to actually transfer this knowledge. So for the likes of Medic, who are the original developers of CHT. So a lot of knowledge, expertise, and a lot of commitment, obviously, to such an important global good. There isn't a very structured way to transfer that to local entrepreneurs. So I think for me, the Accelerator program was very timely in that sense. So 3 things that we did that made us join that program was, one, I think to get the technical mentorship from Medic. Secondly, it was really just around organizational strengthening and business planning so that we can become a better entrepreneur and business to roll out this solution. And then thirdly, we know there are many other IntelliSofts in Kenya. And so we wanted to be part of a community that Medic is setting up. Thank you.
Thank you so much, Stephen. And then now, as we consider Accelerator 2.0, what have you learned? What advice do you have for us? What could a 2.0 look like? What should it look like?
We've learned quite a lot, actually. So I think one, I would say we've definitely learned a lot of, I don't want to call them founders' secrets about CHT that I think are really important, especially for us as a software development company in terms of how do you build quality digital health solutions. And I think technology in healthcare has moved from nice to have, guys who sit in the basement and build stuff for records management to it's now a tool for service delivery. So I think the requirement to elevate the quality of digital health solutions has really, really gone up. And I think when you're talking about things like sensitivity of data and the fact that these solutions can actually kill people if they're not designed properly, then it means that they're held to a higher regard and higher level of quality. So I think that for me is something we've learned. Obviously Medic has a lot more experience working in many countries, unlike ourselves. And obviously, just meeting the amazing people who come from all manner of multiple backgrounds, So we've got a very small team of just technologists, and then then you encounter a team like Medic with doctors, epidemiologists, and because you need all these people to build this solution. It's not just a tech. You've got all these people that need to pour in their brains to make this solution what it's supposed to be. So I think that is something we learned a lot, and I think for us to scale that up, we need a lot more resources for sure, for 2.0. There's a lot, like I mentioned earlier, there's a lot more IntelliSofts in Kenya and many other countries who don't know about the power of something like CHT. And I think we need to find ways to get the word out and get them into the program.
Thank you. Thank you, Stephen. And now a slight pivot to the island of Zanzibar and D3 International. Ricardo, you've been able to, with D3 International, go to scale across Zanzibar Autonomous Region. Now, I think you've crossed about 2,300 community health workers. What's that journey been like in partnership with the Ministry of Health?
Yeah, let's go to Zanzibar. So each household in Zanzibar is now reached out by community health volunteers. Community health volunteers register people in the households and provide the essential health services. So starting from counseling, screening for danger signs, referrals, and they are supported by a digital job aid that helps them to be compliant with the national protocols, and help them to make also a faster job because it helps them to remind them about the health visits and also prioritize the health visits according to the urgency and the relevance. Supervisors are equipped by a supervisory app that helps them to monitor the performance of the community health volunteers and then validate the performance so that they can receive the digital payment later on. Each health visit creates a lot of data. Data is aggregated in dashboards, like the one that you showed, for supervisor, but also at a higher level for decision making. It is integrated into the DHS2. And also we exploit that to enable a personalized care. For example, AI tool that helps to give a likelihood of a pregnant woman to deliver a premature baby, therefore catalyzing the resources. This program is called the Jamini Afia, Community Health. It's co-developed with the MOH and is supported by CHT, by Medic Mobile. More than 500,000 health visits have been carried out so far. 93% of people screened actually go to the healthcare facility for timely health services, which is a huge improvement from before. Now we are transitioning to the Minister of Health. And then allow me an announcement, because it's very fresh news. Next week, the president of Zanzibar will announce the upgrading and professionalizations of community health volunteers into community health workers.
That's wonderful, Ricardo, and you've kind of started to touch on my second question, which is, how do digital health tools ensure that we're always keeping our colleagues like Mary front and center of everything we do? How do we make sure that they are, as CHWs, not just skilled and supervised, but also supplied and salaried? What have you learned, and what can you share with us, and where do you want to go next?
Yes. So D3 is also an active member of the Community Health Impact Coalition, SHIC, and we fully endorse these principles. But Zanzibar is not yet there, despite the political will. And this is where I think there is an opportunity for digital health, actually, and especially existing open source tools like CHT to help to achieve those principles. But with the condition that these are actually adapted to the context, because if there is something that I learned between Zanzibar and in my previous experience, is adaptation. And so that's where the partnership, the collaboration with Medic actually come into place. D3 has been in the country for more than 13 years, hire only local staff. We are enrooted in the country. We worked with the government from day one, and therefore together with the Medic a few years ago, we decided let's build capacity of D3 staff in Zanzibar to be fluent in the CHT and make ourselves the adaptation to the tools. And so, for example, we borrowed from the CHT community the supervisory app. We fine-tuned it to the context. We added additional features, and today this app is fully working at scale. So this is really where I think it's important that there is collaborations, so that we can maximize open source public good digital tools with a condition that is really adapted. And then now we're going actually to the next level, where we, together with the Medic, we are building capacity for the MOH, so that also the MOH is capable to not only to continue to improve, adapt, add additional features, but also ensuring more and more locally ownership.
Thank you, Ricardo. With that, I'm going to pass the mic back to Wambui in Nairobi to ask a couple of closing questions to our panelists there. Over to you, Wambui. Take it away.
Thank you, Krishna. Okay, John, let's now speak briefly about sustainability. So ensuring the new EHS can be maintained over time to support digital health and community health objectives. Why is the CHT as an open source global good the right choice for Kenya in this moment and in the long term?
Yeah, thank you, Ambui. So CHT is the platform of choice for us in Kenya because of it is open in nature. It's an open source tool, and by it being open source tool, we are not paying for us to use it, so that gives it advantage to other platforms. Not because it's free, there are other people contributing into it for it to be developed to the extent that we can be able to use it as a country. But also, most importantly, is that CHT allows for inclusiveness. So we are able to work with other organizations supporting the ministry's agenda in digitization. So currently, we are actually working with nearly all digital organizations in the country that are supporting development and enhancement of each that is built on CHT. And so because CHT allows for that inclusivity, it allows for collaboration, it allows for sharing, up to sharing of the source code, then that makes it a preferred platform or tool for us to use as a country. And because of that, we've been able to fast track development of ECHS based on CHT by working together, not just as a ministry, but the ministry working together with other collaborators to ECHS. And so we find ideal, we find the CHT ideal platform. And in any case, we don't know any other platform other than CHT. That's the only platform that we know. Because if there are others, then they are not known to us. Us as a country, we know CHT as the backbone to our ECHIS.
That's
Thank
a
you.
great endorsement. Thank you, John.
All right.
So our final question to you, Mary. Now that you've worked with the ECHIS and the CHT tools, what do you need to succeed as a CHP, as a community health promoter?
Thank you.
Briefly.
Very briefly. Thank you, Amboy, for that question. Basically, what I need for me and also my fellow community health promoters to succeed is good relationship from the community, level 1 to level 2, where we refer our clients. The reception at the health facility from health providers has to be good. And also what we need to be equipped with tools that we can work with at the community level. For example, I said that sometimes we organize for action days. We need tools like RECs, wheelbarrows, to enable us, as we collect garbage from the community, we have to have those tools so that our work has to succeed.
Fantastic, thank you. So certainly some offline support, but then also allowing with that extra handshake. Thank you very much, Mary. Thank you very much, John. That's it from Nairobi. Handing over to you, Krishna.
Thank you. Mary, that applause was for you. John, that applause was for you. Ricardo and Stephen, that applause was for you. Thank you all so very much. And Wambui, thanks for co-moderating with me. I will do this again with you because it's been so smooth. We'll just close by thanking again the Bayer Foundation, all of our partners, the World Bank, Pan-African Health Informatics Association, the Kenya Health Informatics Association, and of course, Tech Change and the Global Digital Health Network for hosting this incredible gathering. I think it gets stronger and stronger every year. And last but not least, I'd like to thank my medic teammate, Jeff Jacobs, who pulled all of this together, who had Plan B and Plan C panelists who are in the room. We're very grateful to you for being willing to join us in this exciting conversation. And as you embark on more sessions this week, please do reach out to us. We'd love to continue this conversation with you. As a note, we collaborate warmly and collegially with other players in the community health information system place. We believe there's too much work to be done to be adopting a competitive stance. Please do come to our sessions. We've got 8 talks, presentations, demos, a booth at the the booth area where you can come and talk to us, and do reach out. And to everyone who has made these amazing stories possible, thank you. A round of applause for Mary again, and for all CHWs, everyone. Thank you.
Thank you so much.
Mary represents that whole community. And I guess that's why ECHS has succeeded quite well in Kenya and other countries.
And if I could just add to that, we have a service design team within MEDIC, some of whom are former CHWs, and they are actively involved in co-creating with CHWs. So we really do take the human-centered design approach in everything we do. Next question, please. And if you can just let us know if it's directed to a specific panelist as well. Thank you.
Or it can be Steve or anyone on the panel. My question is around how the CHT application takes advantage of existing patient data and facilitates continuity of patient care between the community and the health facility, particularly in light of the comment that the community health worker mentioned that one of the things that they are looking forward to is how referrals are managed.
And I think I'll say really quickly, it's, and I pass it over to Ricardo, it's really just CHT, just in terms of the app itself, makes it very easy to incorporate standards such as FHIR. So if you're trying to get data out and get data into another system, and as long as there's sort of that basic understanding of what standards you're using, then it's designed to promote those kinds of use cases. So it's, I would say, been pretty easy for us to get data in and out.
It's a very good question, because focusing on the community alone is not enough. And this is what the DG has been focusing recently, is ensuring this longitudinal follow-up of patient and of person. This is really fundamental because it's a huge need. This will unleash a huge medical impact, and at the same time a better efficiency. And so, for example, in Zanzibar, only a few weeks ago, we announced a partnership with Reach Digital Health that we are able to actually connect not only the healthcare facilities, but also people, direct to client. So we partner with the best-in-class organization that specializes in direct to patient, direct to people. And we are so glad that we can work on CHT, because we know that the CHT community has put so much work in terms of operability, as Stephen was referring to.
Thank you. We'll take the last question if anyone wants to ask in Nairobi. If not, we can please go ahead.
Dr. Jamshed, Malaria Consortium. My question is, you use the word DHIS, that you are linking data to DHIS2. So you are using it for database to storage, or just only uploading the data from your system to DHIS2?
Yeah, thanks for the question. So we subscribe to the Open HIE conceptual framework at MEDIC. We believe in the importance of building interoperable connections to other parts of a health information system ecosystem. So DHIS2, which you know is widely used in so many countries, is a really, really important interoperability layer for us. The data move once they are entered into the CHT, into the app. They then migrate to DHIS2. That is owned by the Ministry of Health. So they are responsible for stewarding and protecting those data. Of course, what you're seeing is that as you enable digital data collection, first and foremost, it's care giving in the community, which is what all of this is about. The data then come up. They are really, really important in creating visibility about where you have adequate coverage and where there might be gaps in coverage. So at the national level or at the county level or the province level, there's now really good data for decision making thanks to DHIS2 to be able to make decisions. Thank you. And with that, we have to stop our Q&A, but we're around and very happy to keep chatting. Thank you so much for your attention, dear participants here and in Nairobi. Take care.